Hello, my name is Dr. Charles Weaver. I am a medical oncologist and the founder and publisher of Cancer Connect. I want to thank you for joining us today for a pre-recorded lecture and live Q&A on doctor, patient, and caregiver communication. The lecture part of this program was recorded as part of a live Cancer Smart educational event at Memorial Sloan Kettering Cancer Center. To learn more about Cancer Smart, view past programs, and see a schedule of their upcoming webcasted events, please visit www.mskcc.org/CancerSmart. Our experts today are from Memorial Sloan Kettering and include psychiatrists Dr. Allison Applebaum and Philip Bialer, as well as Dr. Andrew Epstein, a medical oncologist. The participants will be available this evening to answer your questions during the live portion of the webcast immediately following the lecture. You will have the opportunity to submit questions during the program. Just type in your question in the space provided below on this screen. The expert will answer as many questions as possible in the time allotted following their presentation. I will now turn the presentation over to Drs. Applebaum, Bialer, and Epstein. Thank you.
We're fortunate to have an accomplished panel assembled this evening who are all leaders in the field of cancer communication. And first, to my immediate right, Dr. Philip Bialer, MD. He's a psychiatrist with expertise in the care and management of people with illnesses, including cancer and HIV/AIDS. One of Dr. Bialer's key colleagues is immediately to his right, and that's Allison Applebaum, PhD. Dr. Applebaum is a licensed clinical psychologist who specializes in helping patients with cancer and their caregivers. And finally, Dr. Andrew Epstein, MD. He's a board-certified medical oncologist and physician, caring primarily for patients with pancreas, biliary, esophagastric, and other gastrointestinal cancers. Communication in its own way is really every bit as complicated as other areas of cancer research and treatment. As we all know from personal experience, talking to our fellow humans can be tricky, fraught with pitfalls, misunderstandings, and missed opportunities. Memorial Sloan Kettering has special expertise in this area. It has the largest psychiatry department of any cancer center and is also a leader in training physicians and other staff in communicating effectively and compassionately with patients. But communication is much more than just how a physician interacts with a patient. It also encompasses interactions that physicians have with caregivers and family members. And an often overlooked but just as vital relationship is the communication between the patient and the caregiver and the rest of family and friends. All of these conversations, or lack thereof, can affect the levels of anxiety, stress, and depression in patients and caregivers. This can also have a significant impact on the quality of life and even eventually on family dynamics. We're going to begin with a brief excerpt that I want to read from a recent essay by a Sloan Kettering physician, Marty Hensley. It was recently published in the Journal of Clinical Oncology and addressed a question most oncologists have been asked at some point. How do you do what you do? People ask me this all the time. Trying to explain how oncologists willingly care for people who die is just too complicated. But sometimes a student or a fellow is candid and courageous enough to ask me, truly seeking an answer, how do you tell a patient that she is dying? So Dr. Epstein, my question is this. The ability for doctors to communicate in a positive way with cancer patients requires extraordinary empathy. A lot of people think that's an innate skill. You're either born with it or you're not. You're either an empathic person or you're not. Is that true, or is it a teachable skill?
I'd definitely be on the side of it being a teachable skill, and I agree that it's one of the most challenging questions that oncologists or any clinician caring for someone with a serious illness can be posed, and I commended Dr. Hensley for giving of herself to what is a large readership in our main oncology journal. It's really a challenging balance for all of us as clinicians to strike, and I think that empathy, or trying to put yourself in someone's shoes and inquire about their emotion is crucial to it. I think it's a teachable skill. Everyone here tries to do that. And I've learned it in different forms, whether it was learning from Dr. Bialer himself or other forums that exist on trying to teach communication, that empathy is a core part of it, and I think, as we'll touch on, a vastly underutilized skill that we as clinicians, especially doctors, need to be doing more.
Earlier I alluded to the fact that caregivers caregivers, not the patient, are often overlooked by medical professionals when it comes to effective cancer communication. Do you believe that caregivers could be an important untapped resource in this dynamic? How so?
Caregivers are absolutely an untapped resource. They're often overlooked by medical professionals. Caregivers are on the front lines. They are intimately familiar with the day-to-day experience of cancer and its treatment, of the lived experience of side effects, and they're aware more so than any medical professional could be of the quality of life of patients. And as such, they really should be integrated into the medical encounter. Oftentimes in my clinic, caregivers will say to me that they felt invisible in the treatment room. And this is a reality that needs to be adjusted. Caregivers are a significant component of the healthcare system in the United States today, and as such should be looked upon by healthcare professionals as members of the treatment team, resources for data, and individuals who can help the physicians to make decisions that are really in line with the goals of both the patient and the family.
Sloan Kettering's communication training program, known as COMSKIL, is designed to train fellows, residents, and other healthcare professionals how to communicate more effectively. How do these improved skills in this area translate into a benefit for the patient?
That's a good question. We're trying to evaluate that a little bit more, how improving communication skills for all of our fellows and residents and faculty, how that does benefit the patient. And we actually just finished a 5-year grant-funded program trying to evaluate that. We're still trying to put together all the data and see what the data shows. But some of our preliminary results show that patients, and the way we actually looked at this, we were video recording interactions in the clinic setting, doctors speaking with patients. And we had ways of coding to see which kinds of skills they were using, how compassionate, how empathic they were. And we asked for patients to comment on this interaction after they were done. And we would look at these recordings before and after the training that the doctors went through. So some of our preliminary results are showing that patients after the doctors went through the training, were more satisfied with their interaction. Many of their communication needs, unmet communication needs, were being met. They felt well, first of all, I'd say our doctors here, I think the doctors here are pretty special. I mean, I think they started with a very high level of empathic skills, but there was some improvement, and patients were saying that they felt the doctors were listening to them more. They were responding to their emotional needs more, and but we're finding that the training is helping in terms of patients having a better understanding of what's going on with their diagnosis, having a better understanding of what's the treatment that's being offered, having a better understanding of their prognosis. We may not be able to teach someone to be a more feeling person. I mean, each doctor is an individual, and they come with their own set of interpersonal and individual ways they react emotionally. But we can teach people to communicate more empathically and to behave more empathically, and that's also what our program is demonstrating.
There seems to be some generational differences in terms of how much information, how it's conveyed, and so forth. My aunt died of breast cancer, probably never knowing that she had breast cancer. You know, this is from a Cuban sort of background, and you never use the C word, and they never wanted to tell her. How do you deal with that?
I smile because that's not an unusual situation that we face, especially in the hospital setting. And I smile because I would bet that your grandmother knew. I would bet that she did know to some degree something was wrong and that she did have cancer. And I point that out because I think that's why I think it's so important to, again, ask the patient what they want to know. And I think families sometimes can be very protective of each other. They're afraid they're going to upset the grandmother, or the grandmother's going to upset the family. But I think, at least in private, ask her, what does she want to know about her illness? And she might say, I don't really want to know too much. I'm fine. Just let me be. And that's fine. I think we should respect her wishes. But if she wants the doctor to talk with her, I think that's an opportunity. Again, ask her what she wants to know, and an opportunity to talk with her openly and give her the chance to express her concerns, her worries, and so on. Learn who your individual patient is, what's important to them, What do they want to know? What do they want to discuss? It's very important.
But Dr. Applebaum, the caregiver and the family often interferes with that communication.
Interferes or perhaps augments
Well,
or
okay.
challenges. It depends. We can look at this as patient-centered care or family-centered care, right? And that oftentimes it's not just about making sure that the needs of the patients are met, but because caregivers are so intimately involved in all of the decisions that are made and all of the steps that go on, that their wishes also need to be taken into consideration. And oftentimes what's manifesting in the treatment room, that's the culmination of many, many, many generations of tradition and generations of silence, for example, perhaps in different cultures. But certainly the family's desires need to be taken into account. So I wouldn't necessarily look at them as hindering. Perhaps they can even augment or facilitate the conversation.
Under good circumstances, but we're here to talk about the problems.
Sure.
And what they're going to do, because they will often want to be protective, not always in a, and that's not always productive, right?
Sure. And I think the best way to protect against that and to make these conversations as most productive as possible is for patients and families to have discussions long before they get into the room with their physicians about what their goals are for that medical encounter. Caregivers should ask permission to ask questions. Is it okay if I ask your doctor X, Y, and Z? Are you okay with that? Or what would you like me to not ask? That way, nobody's toes are stepped on and everyone's goals are really met.
Dr. Epstein, tell me about, the really important thing that is going to make all of this much easier is trust. How do you build or develop that trust both with the patient and the family?
It's very important, and it's extremely challenging. And linking to what you both were saying, I tend to agree with you both. There are myriad situations that occur, and sometimes it will be interference, usually unintentional or well-intentioned, but producing interference, and often it's going to be something that augments. But always, you have to try as the clinician to create trust such that you have teamwork rather than antagonism, which unfortunately occurs not infrequently. So I couldn't agree more with Dr. Applebaum that the caregivers are essential parts, because it's not that they're patients as well that you're caring for, but you are caring for another human being who is verifiably concerned about their loved one, and they're usually anxious and terrified and scared and going through a lot of emotions. And you have to use empathy not only with the patient, but with the family members also. So for instance, when I'm approached with the request to not tell the patients, if a family member approaches me or one of my colleagues, please don't tell my loved one they have cancer. It's a challenging situation, but it's an opportunity to turn potential interference or potential antagonism into teamwork and bonds and a journey that you can travel with the patient and family together. I say, what are your concerns about them knowing? And they might say something like, well, it will devastate them. Or if he knows, then he'll, quote, give up. Or in my culture, we X, Y, and Z. We defer to family members. And then I empathize with that, and I say, wow, it's clear that you really are concerned about them. Let's work on this together. Let's go into the room. And I am obligated to address, as Dr. Bialer said, what the patient, him or herself, want to know. But I promise you I will try to be sensitive, and hopefully you see that, and we can take it from there. And then in the room, I say, Mr. Smith, and I say this to everyone, when talking about health situations, some people want to know all information, some people want to know nothing, and some people want to know everything kind of in between, most details but not all details. What about you? And I think that trust can be built if the family member sees that you're trying, you're recognizing their concerns, to not, as we say, dump information on them, and at the same time to honor the patient's autonomy to, as Dr. Bialer said, have the information that they may or may not want to know.
Let me ask you about what I think a lot of people, in a sense, it's almost the elephant in the room, which is the question that everybody seems to want to ask the physician is prognostic information. How am I going to do? How much time do I have? That always seems to be one of the toughest questions to address. How do you deal with that?
If they really say they want as much information as possible, we can try to give that to them. In our program, we try to teach our doctors to give a range if patients want specific, sometimes patients want specific numbers, or they want percentages, sometimes they want to see diagrams, but we talk about talking to the patient about the most likely scenario, the best possible scenario, and the worst case scenario. We try to talk about a range because we can't always be specific about the person in front of us, but we can give them a range to consider for their specific disease.
There's so much information, treatments, appointments. There'll be multiple appointments to keep track of all kinds of things that are all going to be part of this. And is there a preparation coming to the appointments that's important, that in addition to, of course, as you mentioned, patient and the caregiver need to have their discussions beforehand, but what kind of preparation, what other preparation should be done?
I encourage all of the caregivers in my clinic to try to get a good night's sleep before important medical visits, and also to do something that will take their minds off of the current situation, just even for a few minutes, so that they can have a clearer mind beforehand. That really will help for more effective communication in the moment.
And Dr. Epstein, all of this gets all the more important and difficult as the treatment and disease becomes more complex, because then you really have so much more to deal with. Do you suggest sometimes to caregiver or patient certain things they might want to be, like write down your questions, make sure you come in with questions and you're preparing for your next appointment?
I think that's an easy and definitely important thing, writing down questions, especially, as you said, as things become more complicated. We find that patients and caregivers can get into a sort of flow, if you will. They'll become accustomed to everything from where they park and how they check in, to how long it takes for the doctor to see them and have their chemotherapy and so on and so forth. So they become really accustomed to things, in a lot of ways more comfortable, but as Dr. Gomez alluded to, things very often become extremely complicated as a disease gets worse and death approaches. And so that's where it's really important, not only for the patient and the family, but the clinical team, to be aware that things are getting complicated. And what we try to do when we teach communication is to do simple things, inquire about simple things that are really amazingly under-asked and underutilized, since we don't teach them in medical training, such as checking in about, a lot is going on right now. What are your concerns? What is important to you? And Atul Gawande said it really very well in his book, Being Mortal, that we've failed as a medical society, and particularly in the United States, to care more about simply living longer and how to address what's important to patients when they have serious illnesses. And he says it amazingly simply when he says the best way to do it is simply to ask them, what is important to you in the future? What are you hoping? What are your concerns? Questions like this are open-ended, and they're necessary.
This patient-caregiver communication, sometimes there's for lack of a better term, a conspiracy of silence between the two of them. Neither one wants to bring up something that might upset the other. Tell me about that.
This conspiracy of silence is something I see so often in my clinic, where caregivers will come in and say to me, I just don't want to tell him how I'm feeling. It's going to upset him. And most often, whatever the caregiver is feeling or whatever the caregiver is concerned about, those exact same thoughts are being had by his or her loved one. And what happens is, in effect, by not speaking and not asking questions and not sharing, gosh, what the doctor said to me is so overwhelming. I don't even know what to do with this information. That gives permission to the loved one to be silent. So when one person is silent, the other person is now given permission to be silent. And that creates a disconnect and distance between the two. So I do encourage my patients to think about the fact that likely there's nothing that they're thinking about that their loved one has not thought about at least once. And wouldn't it be great to connect and think together? And I say that these are opportunities that can bring family members closer together or push them apart. So it's really in allowing oneself to begin to speak openly with their loved ones about fears that can bring families together.
Well, tell me about that, because I think most people think of it as a difficult diagnosis, such as cancer, can only add stress to a relationship which inevitably is going to drive the relationship apart or drive a wedge in the relationship,
Sure.
but not necessarily?
No, I tell caregivers in my clinic that cancer is the reason you're coming to me, but it's not necessarily the only thing we're going to talk about. And in effect, what oftentimes happens is that it's an opportunity for a couple, for example, a partner, spousal relationship, to test the strength of that relationship, to recognize how great they are at communicating, how courageous they are in tackling the big questions. Or it's an opportunity to recognize what areas can we work on as a couple or as a family. So really, it's an opportunity for growth.
Obviously, as we said, having a second set of ears and eyes and brain at a given appointment is really important. Do you find very often, though, that patients will try to come in on their own, thinking that I can do this on my own, I'm a tough guy or a tough woman?
That happens, and we hear patients commonly say they don't want to be burdened on others, and often, or more often, that happens at the end of life where patients are dying, and they express that one of their main concerns, usually when it's inquired about, is that they don't want to be a burden on their loved ones. And so more in the active phase of treatment where people are coming and going from clinic, it's less common, but I still see it manifesting. I'll say, oh, Mr. Smith, you're here by yourself today. Are you come on your own? And they'll say, well, I had my sister wait in the waiting room, or my cousin's kind of out with the car right now. I don't want to scare her, or I don't want to get her involved. And that's also a manifestation of not wanting to be a burden on others. And sometimes it's that'll fly, and sometimes I'll say, I hear where you're coming from, and I'm glad you feel that you're coping well on your own, and I think you are. At the time when we get a scan, I always think that it's a good idea for someone else to be there, and I tell them that's particularly around scans where there's a lot of information that we're going to be communicating, and those second set of ears are usually much more helpful than hurtful to that second set of ears.
What about the end-of-life discussions? How does that come up, and at what point does that come up?
Well, in terms of working with families, I encourage them to engage in these conversations early on. So as soon as there's some indication that it's possible that there may be no cure, and that hope for cure is no longer there, though there may be some hope for quality of life, that engaging in those conversations early is critical. There's so many decisions that need to be made early on that it's best to engage in conversations about those as early as possible. It takes a while to adjust to a diagnosis of cancer, and when one has been going through many, many treatments, and eventually when treatments stop working, it takes some time to adjust to that reality as well. And so those conversations oftentimes need to happen again and again and again. Everyone up here, we've talked about having a lot of communication. It doesn't just mean one conversation about one topic, but actually repeating that conversation at various points during the cancer journey.
I know plenty of people who are even relatively rational people who become very superstitious at this point, that if we have an end-of-life discussion, it's going to become a self-fulfilling discussion and prophecy.
And that's what we call magical thinking. The idea that if we are to talk about the possibility of end of life, that end of life would come sooner. And the reality is that there's absolutely no connection between that. In fact, the more and more we can bring that elephant into the room, the better capable a family will be of handling that outcome, should that outcome come to pass.
Let's talk a little bit more about caregiver and something that I think was a term, I don't know if you coined it, but I heard it from you, compassion fatigue. That there's only so much in that well.
The well is usually very deep, but the well does often need to be replenished. Being a caregiver is a full-time job. It's an extraordinarily difficult one. It's also an opportunity for extraordinary meaning making, and for a caregiver to find a great sense of purpose in his or herself. And so while there can be, we talk about burden, and burden can be physical burden, exhaustion, their own medical problems, psychological burden, anxiety and depression, existential burden. Why is this happening? What do we do as a family? Is there a God? All the questions that come up for all of us in hard situations. But it's important to recognize the signs and symptoms of burden, because if a caregiver if that bucket is at empty, that caregiver cannot perform his or her role, and is going to be less effective at communication both outside and inside the treatment room. And that's was one of the reasons why I started the program that I did, to help provide a space for caregivers to replenish that bucket, to learn skills to be resilient, to recognize that it's okay to not always be able to feel like they can support their loved ones. It's okay to feel angry. It's okay to feel guilty. It's okay to feel lots of very negative emotions about lots of many different things. It's all normal. One of the reasons why we've set up in this institution a caregiver-to-caregiver mentoring program is for caregivers to have peers who've been through similar circumstances and who can appreciate the unique experience they're having, and also helping caregivers to recognize that it might also be okay to tell their loved one, you know what, this is hard. I need a little break tonight.
Let's talk about how you help physicians become these better communicators. You're dealing with that, Dr. Bialer, with COMSKIL.
Right.
All of us as human beings, I think, have defense mechanisms. Nobody likes to deliver bad news. Is part of this getting them to overcome these natural defense mechanisms? I think some of those defense mechanisms may turn you into what appears to be a less empathic person, no? You put up that wall because I got to deliver this bad news and then I'm out of here.
Right. So we do try to teach ways of doing that, again, focusing on some issues such as empathy and how to give this information in a caring, again, patient-centered way. So I can tell you a little bit about how we do our training. Again, Dr. Epstein's been involved with this when he was a fellow, but also as a facilitator now. So we do our training with all of the fellows and residents here in the institution, about 90 fellows and residents per year, and also faculty. And so we'll give a brief introductory lecture, but then we break off into role plays. We have actors trained as patients. We have scenarios written for their particular discipline. And we have the physician role play with the actor. And we give feedback on what they're doing, and we give them a chance to try again. And we give them an opportunity to try to learn new ways of communicating and doing this and breaking down some of the defenses.
I hope we've given you some food for thought. Thank you for watching, and thank you for being here this evening.
Welcome to the live Q&A portion of our web chat. We're glad you're able to join us. We've already received a number of questions from you, so let's get started. The first question I have is, how do doctors deliver bad news to the patient? Well, the reality is many doctors don't do such a great job of this. They haven't necessarily received the training to give bad news in a very effective or compassionate way. This is one of the reasons we developed our COMSKIL, our communication skills training program here at MSK. It's called COMSKIL. And when we teach our module on breaking bad news, we try to, again, teach our doctors to communicate in what we call a patient-centered way. When delivering bad news specifically, we recommend, first of all, setting the framework, the agenda for the meeting, what this meeting is going to be about, certainly introducing yourself to the patient, asking the patient if they have any questions that they want to bring up. And then it helps to maybe give a little bit of to ask their preference for information. How much information do they want? Do they want a lot of specific details? Do they want more general information? And then when you're giving the bad news, giving a little bit of a warning shot. Unfortunately, the results of your test showed such and such. So that's how we try to teach doctors to speak with their patients, again, in a more patient-centered, effective, compassionate way. Those are the basic steps. Another question came in if there are other programs that are trying to teach, focused on teaching communication skills. I know cancer centers such as MD Anderson have a program called OncoTalk, where they run 3 or 4 day workshops where people come in from around the country to take a very intense training on improving their communication skills. And what we've been trying to do here at MSK is really make our training very institution-based. We train all of the trainees at our institution on how to communicate more effectively.
I have a question. posed, quote, when patients can't afford the life-preserving drugs that potentially would save their lives, how do you tell them? And that's an excellent question. There's a term, financial toxicity, which is increasingly being recognized in not only the oncology community, but beyond, of how tremendously difficult it is for patients and families to make ends meet in paying for their treatments, cancer treatments, which is, of course, a big one. And there's been work that's even been done here, and someone had done a back-of-the-napkin calculation and indicated that at some point the price of cancer care may actually be 100% of the income of a average family's income. So very scary times that we're in terms of this notion of financial toxicity. And how do you tell patients that? Well, I think the first step is how to get clinicians more aware of this notion of financial toxicity and the real challenge that it presents to many patients and families. I'd say that's really the first step, because we're a long way before really adequately being able to have doctors at least communicate very, very effectively about the cost of treatments, because we're simply not trained in that. So we need to know more. It'll be a long way before we could tell them all the things we want to or should tell them about financial toxicity. But I'd suggest that in the meantime, clinicians should use other clinicians on the team, such as a social worker or a patient financial services representative, to find out what the recourses are for that. And then lastly, the question was aptly used, the adjective potentially would save their lives, because unfortunately a lot of the treatments that are thought to be quote miraculous or quote groundbreaking unfortunately are not as billed, and we need better therapies, and we hope for such better therapies. But we do have an issue of quality with very expensive drugs, unfortunately not providing as much benefit as we would have hoped. So different sides to that question, but I hope that provides some perspective.
So I have a question here. I am a caregiver to my husband who has stage 4 esophageal cancer, and there's no cure for him. My husband does not want to give up hope, but I feel like our time together is limited, and there are conversations that I want to have that involve acknowledging that he is dying. Any suggestions on how to bring up these conversations without dashing his hope? This is a really wonderful question. I've yet to meet a patient or a family member facing cancer who has not thought about the possibility that treatment may not work. And so one way to start would possibly just be to say, I know that this is uncomfortable to talk about, but it is important for us to talk about. You can also begin by putting it on yourself, on the caregiver, by saying, it would be helpful for me. I've been having a hard time not talking about this. And there are important topics that we do need to deal with in the future. I'd also encourage you to think about, and maybe to think about with your husband out loud, the idea that hope may not be something that you can lose, just like a wallet or keys or a watch, that it's not necessarily all or nothing. And sometimes when we think about hope as all or nothing, we also engage in what we call magical thinking, that if we lose hope, we're going to also have a bad outcome. And so possibly you might want to say something like, I'm going to remain hopeful about the possibility for a cure, but also I think it's important to speak about other outcomes.
Okay, I have another question. That's kind of an interesting question. What is the best way to ask what a surgeon's success rate is without offending them? Good question. I think first of all, it's important for you to acknowledge your own fears and concerns about the upcoming procedure, and then to state that explicitly when you're meeting with the surgeon. You know, acknowledge what your fears and concerns are. Ask the surgeon if they'd be willing to share with you experiences they've had with other patients, which can include good outcomes, intermediate outcomes, maybe some bad outcomes. So you see if they're willing to talk with you about that. It's maybe kind of a roundabout way to have them talk about their success rate. And I think it also gives them an opportunity to try to address your fears and concerns.
It's a question from Carmel, California. Quote, a friend told me to bring a tape recorder to my consultation to record what the doctor says so I can listen later and not miss things. I'm afraid this will offend my doctor, but I really like the idea. This is topical and also a great question, and we had touched on it before in a different venue, that it is allowed for people to tape record, and especially that's becoming more easy in this age of technology. So it's sensitive of you that you want to not offend your doctor, and certainly that can be challenging for doctors or other clinicians to be tape recorded because they feel as if they may mess up what they're saying, or that it might be used against them, which is, I'd say, not likely or realistic in general, but you might nonetheless say, I was hoping that I could please tape record this so, as you said, I don't miss anything and I can hear your valued advice. I wanted to let you know before so that you wouldn't be caught off guard. I was hoping that you'd be okay with it. And you're not really asking for permission, because if you ask for permission, then they could say no, which is, again, not right. You're allowed to, but you're almost giving the respect to say that you hope that they're okay with it, and you're letting them know up front. And I think that's the best way to do it.
Another good question here. How can I talk openly about my worries and concerns? And this sounds very selfish, but my own needs. I'm a caregiver to a colon cancer patient. Well, first off, it's very important to acknowledge your own needs. The fact that even you're asking this question implies in some way that to be a caregiver, to fulfill that role, that one needs to put their needs aside. And that's just not truth. Cancer is a disease of the family, and in order to face cancer as best as possible, it means attending to your own needs. Many caregivers find that they feel particularly guilty expressing these needs first to patients. And so I would encourage you and others to practice sharing these needs with others in your world, whether it's friends, colleagues, a social worker, other mental health professionals, to get comfortable with saying, you know, I'm having a hard time right now, feeling very anxious or overwhelmed. That might help you to feel a bit more comfortable before engaging in that conversation with your loved one who's a patient, who I'm guessing is going to be very appreciative of your honesty and probably very understanding that your role is a difficult one.
Okay, another very interesting question. Are there resources that could help deal with family dynamics? I have several siblings. We are trying to make decisions for my elderly mother, but who was in relatively good health prior to the cancer diagnosis. We all have good intentions for my mother, but the added stress of battling each other is overwhelming. This is a common problem, especially when dealing with very emotionally charged situations such as cancer. I know certainly here at MSK we have a very good family therapy program. We can see families on an outpatient basis. Also with our COMSKIL training, we have a module that focuses specifically on conducting a family meeting, and we try to teach our doctors how to run a family meeting in conjunction often with a social worker, often with a psychiatrist or psychologist, a multidisciplinary kind of meeting to try to address some of the family dynamics. Depending on where you are, there may be some other resources, either through psychiatry clinics. Here in New York, we also have an excellent institute called the Ackerman Institute for Family Therapy that works very much with many family situations, but also with medically ill patients. And there may be family therapy clinics in your community also that can help with situations such as this.
The next question is from Boston. My doctor used to speak to me and look me in the eye. Now he sits at a computer screen and he types without looking up. Is this really necessary? So I'd say you're not alone. This is something which is prevalent now. Again, technology is upon us, and doctors are having to document on a computer during the encounter, and it is unfortunately a reality. And I think in the end it becomes a matter of whether or not you've weighed it up as something that's worth it to you in your relationship with your physician and what he brings to the table, in spite of the interruption really that the computer brings. There's increasingly more and more written about what doctors can do to not let it be as much of an interruption. But from your vantage point, I'm not sure per se there's something that you would be able to do to change your doctor's behavior. That may or may not happen. So at the very least, I could say this is a reality, and it's challenging, and it's frustrating for lots of people, and you have to do ultimately what you feel most comfortable with. And that may include saying something like, "Doctor, I really value your help and appreciate it. Sometimes I feel like the computer is getting in the way of you and I really connecting." That might be something that you feel comfortable or not comfortable saying, and it may or may not result in change. But it's definitely an increasing, frustrating reality that we all deal with.
So next, my spouse is having a terrible time with his diagnosis. I know deep down he is just scared, but he has reacted by withdrawing from our family and using criticism. We have 2 children. This is hard on all of us. I feel like some outside help, like a counselor, might help him to come to terms with some of this. Do you have any suggestions on how to bring up the topic of counseling without making him feel even more withdrawn and isolated? This is a great question. The way that your husband is reacting is incredibly common. Withdrawing certainly is one way in which many patients who are fearful and anxious and overwhelmed will cope. So I agree that professional support would be helpful in this circumstance to facilitate more open communication with him, and certainly to augment communication within your family. Oftentimes I'll tell families that I work with that most families facing cancer don't have mental illness per se, but can definitely benefit from professional help. There's still a stigma around receiving mental health care, and so sometimes just saying, all families facing cancer have a hard time, and we could really use some help. Just to normalize it a bit could be helpful. The other context to bring up is just to say that our engaging in some sort of support is not only going to be helpful just for the 2 of us, but for our family as a whole, particularly for our children as well, and framing it as the health of the family moving forward.
Okay, my next question, it's kind of a long, complicated question, so I'm going to see if I can distill it down to the main points. This is coming from Santa Rosa, California, and the question is saying that in our current medical system, it seems like doctors rarely have the time to really sit down and the presence to take notice and check in and engage the patient fully to see if they can really talk about what's important to them. So in your research, is your research helping to change procedures such as how much time a doctor has with a patient in order to allow for more human connection and compassionate process? I think that's very much what we're trying to teach in COMSKIL, how to, in some way, structure your interaction with the patient so you can be more effective in your communication, but at the same time be more patient-centered, which is what we keep trying to promote. Trying to learn who your patient is by asking the right questions, trying to learn who they are, and learn what their concerns are. What do they want to get out of this meeting with you? I think this can help in the short amount of time the doctors have, again, to make their communication more specific for your particular patient and that particular interaction, their particular concerns. And I think if the doctors, we've trained have found when they learn this structure, it does help them work a little more efficiently in the short amount of time they have. And I think the patients are thankful for this and find their interactions more useful.
The next question asks, when do you know it is time to, quote, come to terms, close quote, versus looking for more options, more opinions, more clinical trials? How do I effectively tell my doctor that I still want to fight when he is telling me that my options are running out? And I empathize with this. I can't imagine what it's like to have the notion that you're still fighting for something and the doctor is telling you perhaps what you're feeling to be the contrary, that the options are running out. So this is a very common and a very difficult situation. And I'm not sure if coming to terms, as you put it, is mutually exclusive with the other really effective things that, that you listed, or things that can be effective, like looking for more options or more opinions or clinical trials. Sometimes that's part of the process of you coming to terms with the situation, and you again have to do what is most comfortable for you, which is easier said than done. But if no longer seeking out more opinions or clinical trials or any cancer treatment options is what you believe is best for you, because of what your own personal values and goals and aspirations at that point in your life are, then that is the best decision for you. How to effectively tell that you still want to fight? I task you with the very big challenge of considering what you're fighting for. And that may or may not mean more time to live. It may or may not mean other things that are important to you, like making a certain milestone in your family, or making sure you say goodbyes or other things to loved ones. And when you get a sense of what's important to you to fight for, you can communicate that more easily, even though it's very challenging to communicate that to your doctor and other people that are trying to help you.
So a really great question just came in. I'm having trouble bringing up the subject of end-of-life discussions. Do you have specific suggestions or perhaps a resource you could refer me to break the silence? I literally freeze every time I try to bring it up. And of course, it's understandable to freeze up bringing up this topic. It's overwhelming to all patients and families. So the first piece here is to acknowledge that this is not something that should be one person's responsibility. And I encourage you to really take advantage of your family's providers, whether it's the oncologist or the nurse or social workers or anyone who's in the system, to help facilitate these conversations. Oftentimes it's easier when a professional begins the conversation and then a caregiver and patient can continue it after the meeting. I also think that practice is helpful. Sometimes just forming words the first time can be really overwhelming. So I encourage caregivers to practice saying things out loud to themselves, to a therapist, to their friends, to the wall, just to get comfortable saying certain words so that they're less overwhelming the second time. The third thing here is that oftentimes families feel like these are really big conversations that maybe are just monumental and need to happen once. Oftentimes there's so many different things that go into having these conversations that need to be accomplished. And so I'd encourage you to think about maybe breaking up the conversation in terms of different key elements that need to be addressed. And that might make it feel a bit more manageable, and maybe just bring up one piece that is maybe particularly time sensitive or might need the greatest amount of conversation.
I have one last question here. This is kind of connected to the question about whether communication skills are being taught in other medical centers. There was another question about whether communication skills are being taught in medical schools, which is a very important place to start this training. To my knowledge, it is being taught at some medical schools to some degree. Some are better than others. Almost all medical schools, I think, at least try to teach their students how to break bad news. That's the most common communication skills kind of training that's given. And I think it's very useful and very necessary, very helpful, because it's often the youngest member of the medical team in a hospital, the intern, who's giving the results of tests and so on to the patient, and sometimes giving it alone at night when they're on call. And if they have some way to learn how to do this, and again, in a more patient-centered, compassionate way, it's going to be very helpful.
This question is from Florida. How do I tell my doctor that I'm tired of trying new treatments? He has been great. I just feel like my body can't take much more. I've been dealing with stage 4 breast cancer for 4 years. This is another courageous question and perspective, and I would urge you to use the exact same words that you've posed in the question. Doctor, you've been great, and I feel like my body can't take much more of these new treatments, and fill it in with whatever it is, the fatigue, the loss of appetite, the trips back and forth to the cancer center, whatever it is. and really say, I hope you don't feel, or you may consider saying, I hope you don't feel upset with me. Some patients are concerned with upsetting their oncologist, but you may not need to say that. You don't even have to say you've been great. It's your rights and within your rights to say, I really feel as if I want to change directions and stop these cancer treatments, and I want to focus instead on whatever it may be, spending time with my family, maximizing treatments of my symptoms, and I think that that's the best way to state it, and that your team will likely come around to understanding your perspective. And if they don't, then you've at least stated it, and that's what you need to do.
I think that's all the time we have for questions tonight. Thank you for tuning in. We hope that this has been helpful and informative for you. If you'd like to watch the webinar again, it's going to be available on www.cancerconnect.com, and have a great night.